Hello and welcome to this series of interviews for the National Council of Hypnotherapy Conference 2022. I have the pleasure to interview Sheren Gaulbert on a profoundly important topic, treating the person in pain. So welcome. Thank you for joining us.
Thank you for having me.
Oh, and I'm really looking forward to your talk at the conference.
Oh, good. It's so important.
Oh, it is. And I think it affects so many people and indirectly affects so many more.
Absolutely.
So if somebody hasn't come across your work before, Sheren, could you give us a little bit of background how you got into pain management and pain research?
Good question. Let's start with my personal experience with pain, with persisting pain, or persistent pain, rather than calling it chronic. Chronic sounds like it's forever or something chronic. So persistent pain or persisting pain is better. So I lived with intermittent pain for almost 4 decades, perhaps a little bit over 4 decades, actually.
Wow.
And I was in and out of hospital, but actually, that wasn't too bothersome. What was really bothersome was around the age of 21, I ended up with persistent pain. And it was persistent pelvic pain, vulval pain. And it changed my life rather quickly. And I got worse and worse. And I got to a point where I spent around 10 years of my life in the worst pain, passing out regularly from the intensity of the pain with no answers. I'd seen a lot of the top clinicians. I'd tried all sorts of therapies, including hypnosis, which didn't work because it was pain relief hypnosis, which, was completely unethical for the situation I was in. We might come on to that.
Yes, I could be keen to ask you about that.
So I had my own experience with pain. Now, look, I eventually broke through because I became quite determined. I was young. I wanted to find a way out through this. I was told this would be my life, that I would get worse and worse, and I would have to take a lot of bed rest. And I spent many, many years just holed up at home, unable to go out, just in bed. And the pain spread to other parts of my body so that it was getting more and more difficult for me to move around. Awful state of affairs for a young person. But good news, I broke free and was because of self-hypnosis. And there was nothing in that self-hypnosis script that I recorded in a funny voice, because that's what I thought self-hypnosis was all about. In a funny, calm and relaxing voice. Of course, I don't use that voice anymore. And I started to notice a difference in that I could get out and about a little bit more. Now, my pain didn't completely disappear. That happened after I trained as a cognitive hypnotherapist in 2010. And I took myself through what has become quite a life-changing experience, because as I started to break free, I wanted to know what's happening here. Why am I getting better? And I'd made a promise that once I found a way for me to break through, considering the amount of therapies I had tried, and I am very scientifically minded, so I trialed things for 4 to 6 months at a time without anything else, so that I can really determine whether this thing is working. So I wanted to know, this was working. Why is it working? What's going on? I can't share this with other people until I know what's going on and whether it's appropriate to share with other people. So that's where I got really interested in the science of pain, trained with the Neuro Orthopedic Institute. But my life these days is immersed in pain science and pain biology, pain neurobiology, pain neuropsychology, pain neurophysiology, all the pain science words you can think of, and the immune system, psychoneuroimmunology, right? But ultimately pain science, because what we understand about how pain works moves very, very fast. So let's talk hats, John, right? Yes. Where I am now. I'm a pain science educator. I work with multidisciplinary pain clinicians, want to work with patients ethically. This is really important. Want to work with patients ethically in line with what we know about the science of pain. The brilliant physio clinician researcher Lorimer Moseley, who you may be familiar with, wrote Explain Pain with David Butler. In a training a few years ago, he stood up and right at the start of training us, he just said, if you are practicing what you were practicing 2 years ago, with your patients, with your clients, then you may be doing more harm than good.
Wow.
This is a wake-up call. We need to move with the evidence that we have, and things are fast moving. So I'm a pain science educator working with multidisciplinary clinicians. I do rock up on pain science events, webinars, conferences. I travel around in better times doing that.
Yes.
Next year, hallelujah, I'll be in San Diego Pain Summit. I will be there in person this time rather than online, but you will see me at these big events talking pain science and what we can learn from different modalities, because we know that multidisciplinary care is the best kind of care for people living with persisting pain. And I think we're going to probably come on to a little bit more on that in a bit. Look, I also am a trustee of the Bible Pain Society because of my own experience through pain. I eventually decided, yeah, you know what, I am going to say yes to this post. And so I run live streams, webinars, compare the conference, which is in person, hasn't been for a couple of years. And that brings together multidisciplinary clinicians, consultants, doctors, all interested in pain, and patients all in one room so they can learn from each other. This is a great opportunity to learn from each other. And so at the moment, we do our live streams and webinars, you know, everything's online at the moment. And then you've heard me mention I'm a Quest Institute trained cognitive hypnotherapist, QCH, and that framework really fits beautifully with what we recognize within pain science. Does that answer your question, John?
That's fabulous.
Rambling that.
Excellent. So I'd like, you've mentioned a couple of times sort of pain relief as being unethical in some ways. I wonder if you could expand on that for us.
Okay, so look, if we think of acute pain, first of all, if someone has an injury and we decide to use a pain relief technique, then that pain, of course, is there for a protective reason. It's telling us to take action, go and seek help, do something about this, or keep it still or protect it for a while before you can do the movement. So that pain would be really unethical to get rid of. When it comes to persisting pain, things are slightly different. So the tissue injury healing time is around about 3 months. It can be up to 6 months. So if we have an injury or there is an infection or there's something that sets off the pain in the first place, it takes, it can take, if there's a serious tissue injury, 3 to 6 months to get better. Anything after that we call persistent pain. Now, then we are interested in what else is going on here, because this pain is no longer serving a purpose. Often clinicians or hypnotherapists might think, okay, so pain relief, we need to look within hypnotherapy. We have some wonderful tools, and it's not that I'm saying don't use control room of the mind or submodalities cure or these pain relief techniques. There is a time and a place to use them sparingly, because we want to understand what is happening within this individual. We can be looking at a sensitized nervous system that the person is, and let's look at the bit we're interested in, the top-down mechanism, where the brain is involved in working out whether the person has a threat, a potential threat, or they're safe. And what is happening is there's a decision being made, an unconscious process, if you like, being made, that this person is still in danger. There is still a threat, regardless of whether there's any messages coming up from the nerves or not. Doesn't have to be any messages coming up from the nerves for this process to happen. It's a bit like this 11 million bits of data coming through our senses at any one time, and this processing that happens, that much of it gets deleted, some of it gets generalized and distorted to fit our beliefs. And it's looking at past experiences or past perceptions of experiences to draw upon to decide upon whether someone is in a threatening position or someone is being threatened, and so it may release chemicals, which I call amplifiers, which I'll go into in the conference, or muters if this processing deems that the person is safe and context is important. So why is it unethical to take away pain? Well, because this is a complex process. We need to work out what is this match being made up here, is matching up to this is a threat. Let's work out what that threat is. Let me tell you what happens in my day-to-day life. Most of the people I see come by referral from other clinicians, from physios, from medical professionals, all over. But people tend to not just stumble across me. They are referred on. And many of them, look, I would say pretty much all of them will have tried some form of psychological therapy at some point, and it's not worked, or it's given them part of the solution. Some of them, a percentage of them, will have seen a hypnotherapist at some point, and either it will not have worked, or it's worked for a period of time, and then their pain has come back, and it's come back worse. Now, do you remember me saying that I trialed hypnosis really early on when I was unwell and it didn't work?
Yeah.
Well, there were periods where I kind of, that feels a little bit better, because I was relaxing. I was temporarily relaxing the nervous system and taking myself into that parasympathetic activation, safe mode, rest and digest mode. However, it didn't last, because the pattern match that was happening unconsciously hadn't been looked at. That hadn't been reprocessed. All I was doing was calming the nervous system without any without looking at what was really going on, if that makes sense. Pain can come back much worse after a period of time, even if someone has experienced a period of relief. And when that comes back and they've seen a hypnotherapist, can you imagine what might be going through their minds? It's not worked. I've failed. I've been told that this will work. I've been told not to come back because it works.
Yeah.
Best case scenario, they go back to the hypnotherapist, perhaps, and delve into that, or find a therapist that will help them through that. Worst case scenario, they just think they failed. Yet another treatment that's not worked. If they come through to me, then I will be looking at what are the different things going on here that may be releasing these amplifying chemicals that leads to that unconscious, that has started with that unconscious processing, which is deemed there to be a threat, like there's a saber-toothed tiger in the room. We need to uncover that. And even if we uncover that, then just reprocessing that straight away may not be the right thing. We've got some great tools to use, so we might think, great, let's just dive in there with timeline or some sort of reprocessing, whatever that might be for the hypnotherapist. But we have to look at the person sitting in front of us. If their nervous system is highly activated, when we throw in a reprocessing technique, it can temporarily dampen things and then heighten things, and there can be a boomerang effect. And their nervous system is already processing quite a bit. We don't need to chuck in something else. So we need to really look at what do we need to do first with this person, and go at the pace that is suitable for the person sitting in front of us. And that's going to be different for each person.
Wow.
Does that make sense?
Yeah, it does, absolutely. There's so many places we could go with this.
Yeah.
One of the things I know you're going to talk about is the correct interpretation of the social model.
Oh, yes, biopsychosocial model,
Yes.
BPS model. This is great. So George Engel conceived of the biopsychosocial model a long time ago, back in the 1970s. And we now hear of it a little bit like this, I treat people according to the biopsychosocial model of pain. There's no such thing. There is a biopsychosocial model of health, if you like, of well-being. And let's take it even further. Just us, our being, our human experience is biopsychosocial. So what do I mean by this? Actually, before I go into that, let's have a think about this. What has happened with the biopsychosocial model? When people hear that, they think what is being said is it's all in your head.
Yeah.
They are only hearing the psycho bit, the psychological bit, biological, psychological, social. They're only hearing the psychological bit. It's biological, psychological, social. These things are interlinked and intertwined all of the time. There's no such thing as emotional pain. There's no such thing as physical pain, because all of the time, 100% of the time, every pain we feel has elements of all of these all of these, emotional and physical, or biopsychosocial. It's a biopsychosocial experience, if you like. In recent times, there's been a move towards psychological therapies for pain, and we're missing out. Is there a biological, and when we do psychological therapies, there's a part of that that's going to be biological. If I'm feeling an emotion like peace or calm or anger, there's biology happening right there inside of us, right? When someone is experiencing pain, there's biology happening inside us, amplifiers or muters. There are complex interactions between the different systems in the body happening all the time. And there's a social element as well. So for the person, let's imagine a person going to a restaurant and they're with a friend, and this person quite likes garlic and smelly cheeses. And there's people around and they're tucking in because they love it. They're having a biological experience of they're loving this, psychological experience of all the lovely feelings they're having. And a social experience because they're sharing this time with their friend. But hey, it's also biopsychosocial for the other people around. Some people may not like garlic or smelly cheeses. So they'll be having their own biology going on and their own psychological processes and their own social processes, i.e. I'm in this social setting. There's always this dynamic. How does this apply to the person in pain? If someone's been experiencing persisting pain, and you may find there's a level of hypervigilance around their pain. There are things they might avoid doing, for example. Let's talk pelvic pain. Someone is about to go and sit in a conference and they see the chair and they think, oh goodness, I've got to be sitting in that chair all day. How am I going to do it? I know I'm going to be in pain. There's all sorts of processes that I'll talk about in the conference going on in that moment. So there's already a biological process happening here because they're getting feelings, they're biological, a psychological process going on there, and a social process. If they feel I'm not going to do it, they are removing themselves, and we are social beings. They're removing themselves from a situation and avoiding it because they feel like they can't tolerate it. And
That's
that
going to
might
cause
be
even more problems, I should imagine.
Absolutely, of course. Even more amplifiers, right?
Yeah.
So, you see people's worlds shrinking because they've been experiencing persisting pain. They don't go out and see their friends, or they don't go out to or go and travel because they don't want to sit in the car or don't want to sit on a train or whatever it might be. So you see their worlds shrinking. So this is what we mean by biopsychosocial, is we need to have a look at the whole person sitting in front of us. So not just psychological, because when we're doing psychological interventions, there is an element of biological and we need to factor in the social.
This could have been an exciting talk at the conference. I can tell already. I'm entranced with what you've been talking about.
Good to hear. Yes, there's a lot that we're going to dive into, factors that can amplify, factors that can cause the muting response, and that's kind of what we want. And I'm also going to dive into happy hormones, these so-called happy hormones that can be far from happy, right? So we're talking serotonin, oxytocin, endorphins, dopamine, lovely things, right? Let's take oxytocin, the cuddle hormone, the love hormone, lovely. But you know what? These all have a dark side to them too. And we need to figure out whether these are already being released within the people sitting in front of us that might be causing a detrimental effect. When there are muters, there can also be amplifiers. So we need to really assess whether that's going on, and if so, those could be the muters we focus on to replace. If we take away serotonin that's being produced for a purpose that is also then producing amplifiers, we need to figure out, okay, another way of producing serotonin. We can't just take that away. But more at the conference on that. So happy hormones aren't necessarily happy.
Wow, it's fascinating. Absolutely. So I'm really looking forward to seeing you at the conference. And
Great, really looking forward to it.
Thank you ever so much for agreeing to talk.
Oh, it's a pleasure. Yeah, it had to happen at some point, and I had to say no in the past, and here I am saying yes, and this is absolutely the right timing. And actually, there's something quite exciting happening this year. Whilst I already mentor, I mentor clinicians, multidisciplinary clinicians, and I also mentor hypnotherapists one-to-one. I am launching an opportunity for any hypnotherapist wishing to work with that person living with persisting pain more ethically, better, in line with what we understand from the science. I'm launching an opportunity for them to benefit from my knowledge in a better way, should we say, in a different way for growth.
And is that what you're talking
more on
about?
that
You're
end.
doing an announcement at the conference.
Yes, that's it. That's the
Ah,
one.
how excited!
It is.
You'll be so generous with your information, and I think that seems a good place to sort of leave it. So thank you.
Thank you so much, John. See you there.
See you there, yes. Tickets are available now. So head over to hypnotherapist.org.uk and look for the conference, and we'll look forward to seeing you there. Take care. Bye.
Bye.
Bye.